Bone marrow. Bone marrow. Proliferative means proliferate. It grows. Right? So here, what's really happening is that it is the bone marrow which has been told was banao, right? Increase RBC production. So increase RBC production. So RBCs, they are increasing. RBCs are increasing, so they are just the packets, and there is hemoglobin, right? So they are getting produced more by the marrow. So they are getting produced more by the marrow, and it is happening. So there is increased RBC production. That's why the hemoglobin level is high, right? So this makes complete sense. Right? The second thing is so interesting. So for example, COPD. We have learned respiratory disorder. COPD is chronic obstructive pulmonary disease, correct? Now in COPD, lungs are not functioning well. Right? So because the lungs they are right, lungs they are not functioning. So what would happen? It will lead to decreased CO2 O2 exchange. That means this thing will lead to hypoxia. Because there is low O2, low oxygen, so it will go to kidneys, right? And it will say that you release what is called as the erythropoietin. It is called as the erythropoietin. Now this erythropoietin is that substance which is quite misused also. In India, it is banned. But this erythropoietin, there is exogenous erythropoietin also. So in some of the gyms, they say this much bottle cost 5,000, 7,000, 10,000. Right? So basically, it is a exogenous erythropoietin. So exogenous erythropoietin, that means if someone is swallowing those tablets, what kidneys are doing when the blood is having less oxygen, now kidneys are doing because of this. So this erythropoietin which wants to be released by kidneys, it is given directly to the body by those tablets. So this erythropoietin, whatever happens, it will go to bone marrow. And bone marrow, when we say it can start producing more RBCs. More RBC, so problem of oxygen is solved, right? And it will lead to increased oxygen and the life is good. But those athletes, what they do is they start taking erythropoietin. There is a very wonderful film on this, right? Because say more, it is not so that more number of RBCs that everything is good, because this will be a major thing for the blood clot. Right? Obviously, space is limited. Now more number of people are there, so there will be more congestion. So that's why they'll be triggering it much more. That's why when such things are, that is what is called as the exogenous. Right? I'll just write it over here. So you keep it in mind. So exogenous EPO, erythropoietin. Right? It is banned. Apart from steroids, right? Levostalenthol and all these medicines, right? If they are taken, so they give tremendous athletic performance because body forgets what is called as fatigue. So it will keep on working. That's why all these things, they are banned. So they will be excreted. You will find that they take the blood sample, they take the urine sample. Because during metabolism, either it will be released into the blood or into the urine. So when those samples are taken, so you will find the presence of these drugs. So in Olympics, every athlete is tested for all these banned substances. Right? So when we'll be discussing exercise physiology, at that point, one day we'll be discussing all the banned substances, why they are banned. Right? There is a very good reason behind it. So this is the thing. Third, what we do. Yes, what we do many times. You wear a mask. And in that mask there is a control, right? There is a control. So because that mask is airtight, so what if you adjust that, so there is an aperture, so through which the air will come. You decrease that aperture. So this is like a high altitude simulated altitude simulated sports. So as if you are working on high altitude, right? Now, obviously, this is like you are giving less oxygen to the body. When you are giving less oxygen, the kidney will fire up, bone and marrow will work up. But this is happening into its most physiological way, and that also only once a week. So that way, gradually, you are improving performance of your body. But along with that, yes, be very careful that yes, it can lead to blood clots. That's why one has to drink large amount of water, right? Large amount of water, so that nothing goes wrong. Plus, you need to monitor your blood pressure very strictly, right? So that you are not going for any of the fluid overload. But easy to do. But yes, body will never go wrong if you try to do this thing. So this is high altitude. So in all these cases, you'll find that your hemoglobin level will be low. Complications, right? Complications. The first indication that this is like a practical itching. It leads to itching. If it is itching, that means immediately don't do this. Right? And second is it can lead to formation of blood clots. No doubt, blood clots, that is at a very later stage. And how will you manage? Management, very simple. The most sasti tablet, right? Aspirin. Aspirin, right? So if it is like such thing like polycythemia vera. So in that case, the patient has to pay. Say for example, even when the patient is on myocardial infarction, in all those cases, this aspirin is to be taken almost non-stop. Then hydrocarbamide. Just remember this name. Is one of the very effective for the treatment of this polycythemia vera. Polycythemia vera. This is what we call as a myeloproliferative disorder. Right? So this is about when the hemoglobin level is high. When it is low, so then we call this thing as anemia. We just add, in fact, we insert some pages. So when it is high, you are clear. But if it is low, so then there are so many things. Then starts your analysis. And this is what we shall do today. So it means hemoglobin level is low. So checking hemoglobin, that would be your step one. That would be step one. So what next? Immediately you check for MCV. That would be your step two, mean corpuscle volume. Right? This would be divided into three parts. If it is normal, now anemia is there, right? Hemoglobin level is pakka low. But what about the volume of the cells? Now, the normal range of this is about 80 to 95. 80 to 95%. It is not of MCV, right? Of MCV. If the MCV is less, that means what? Mean cell volume or the mean corpuscle mean cells, right? So mean means you are taking average of all of them. You are taking every average, right? All the million cells, right? You are taking average. In that average, if it is low, that means most of the cells, they are small. Making sense? Right? Most of the cells, they are small. So we'll be calling this thing as micro. Micro means small. And cytic, that means cell. So it is called as the microcytic anemia. When the MCV is less than 80. Easy to understand? Then if the cells are normal, we'll be calling it normocytic. Right? We'll be calling it normocytic when it is falling into the range 80 to 95%. Right? So it is normocytic. And when the average value is bigger, so it would be called as the macrocytic. So when the value is more than 95, so easy. Now anemia is there, only the hemoglobin, right? So don't jump on hemoglobin less, was anemia, but there can be other things also. There can be so many things, right? Hemoglobin level is less in the blood, in the cell. So watch for this second step, right? That is the mean corpuscular volume. Clear? Now, what is this? We go for a fresh page, right? More. So we take here. So hemoglobin was less. We went for MCV and we came across three things. That either it is normal, either it is low, or it is high. If it is low, we say microcytic. Cells are small. There can be some reasons. One of the reasons is iron deficiency. Iron deficiency. That is the common thing. Now, iron deficiency, iron is less in the body. Right? So, what could be the reason? It could be blood loss. Blood loss. Now, if it's a young female, right, you ask for that, are the periods heavy? The periods are heavy. So, that means that the amount of blood loss that would be so heavy that even in spite of the, and then you ask for the diet. If the diet is poor diet, and if the female is in stress, so obviously her hemoglobin level drops sharply. If it's a male patient, you ask for whether there is any pain in the abdomen, so you will be asking for the celiac disease. So these are some of the common things, iron deficiency. Or say this value, this is, we are talking about the microcytic, right? Microcytic. You ask for the inflammation, any of the chronic inflammation. Any of the chronic inflammation that will lead to microcytic inflammation. And the third very important thing which we need to diagnose, and that is what is called as the thalassemia. Thalassemia, because it is an inherited. Right now, we are not going into the details of what is alpha thalassemia, beta. We'll take it separately in the hematology. But today will be, at least we'll come to conclusion, iron deficiency or thalassemia just from the fact. We'll just go next 5 minutes. So in short, in thalassemia, because of some inherited disorder, there is decreased hemoglobin production. That hemoglobin, which is not either not efficient, is not working, it is less. And the cells are small. So this is what we get to do. So over here, now we just learn one more thing. What about the normocytic? So what is normocytic? Mean corpuscle volume, that is not, but the hemoglobin is less. Hemoglobin is less. So when this thing occurs, so this is normocytic. Right? In normocytic, the commonest one is there is blood loss, right? But this is an acute blood loss, injury. Some injury has occurred, right? And there is acute blood loss. Just a matter of few minutes or few hours. Right? Heavy bleeding, right? Some injury and large amount of blood has been lost, maybe some accident. Even in chronic inflammation also, it can be normocytic. It can be. But the most important is, say for example, in case of myeloma, right? This is the bone marrow cancer. Bone marrow. So when the bone marrow is involved, you remember you need to do what is called as the pancytopenia. Pan means across all. Cyto means cell. Penia means it is decreased. Right? So it means what? There is decreased RBC, there is decreased WBC, there is decreased platelets. All three are decreased. So when such thing happens, you suspect myeloma. No doubt there will be other signs and symptoms of it, but this is in general. Okay? So this is like what we see in our cell. And when it is macrocyclic, this third one will be the macrocyclic. Right? Macrocyclic. When the cells are big, right, but the hemoglobin is less. In this case, do suspect B12 deficiency. B12 deficiency. Or folic acid or the folate deficiency. Very common. If they are normal, then do examine for autoimmune disorder. Autoimmune disorder. So in autoimmune disorder, there can be so many things, but one of the things is like, say, what's called as the spherocytosis. Spherocytosis. What is the normal shape of RBC? It is like dumbbell shape. This is RBC. It is a normal shape, dumbbell shape. So if you are watching it from the top, the central portion is depressed, right? So there is a concavity. Over here, in case of spherocytosis, the cells will become like sphere. Right? So this is cytosis cells. Most of the cells, they have become sphere. These are the cells which will break. So that is what is called as the spherocytosis. Then other reasons are like, say, alcohol. That can lead to it. One of the very important things when you want to coordinate it with the T3, T4, TSH, right? Thyroid. So in case of hypothyroidism, also it can increase, right? So macrocyclic. Now we'll be learning the method about what to do, right? What to do in such cases, and when the report is in your hand. So this is like we are going into slightly more detail. One, I'm giving you one algorithm, and then we'll practice it on 3-4 patients. So here it is the first step what you took it, low hemoglobin. Right? So this is your step 1. Right? Absolute focus just on one page and then see how interesting it becomes. The step 2. Step 2 is you go for MCV, mean corpuscle volume. Right? In this, our focus right now will be purely on low. Right? Kitna low? Less than 80%. Right? So if it is less than 80, they will be calling it microcyclic. If it is microcyclic, then we move on to the step 3. Right? This is step 1. This is step 2. Right? So hemoglobin is step 1. MCV is step 2. And then comes our step 3. That's at step 3, which is called as the RDCW. Or it is also called as the RDW, or sometimes in reports you find that it is either called RDCW or RDW. Both in one of the report it is written like RDCW. What it is? Basically, red cells distribution width. So, red cell distribution width, its importance. So this becomes like our step 3, right? So step 1, step 2, And now we know what is to be watched, and that is the step 3. RDCW, if it is more than 15, very specific, if it is more than 15, then you are dealing with iron deficiency. And if it is less than 14, then we are dealing with thalassemia. But stop. This thing, this step 3, it is good to watch, but we need to confirm. And that confirmation is step 4. We'll just have a practically we'll see these cases. And this step 4, what is called as the, now at times you might have to calculate it. Right? It is what is called as the Menzer index. Right? This is the Menzer index. What Menzer index is? There is little bit of maths. Little bit. Menzer index is MCV, right? Mean corpuscular volume, what we saw, divided by RBC count. So now this is a new number. Yes, it is a new number, but we'll see that. So it is called as, in some of the reports it is calculated. In some of those reports, if it is not calculated, you have to calculate. So in that case, MCV you have already seen, and you will be going for the RBC count. This Menzer index, if this Menzer index is more than 40, right? I take it like this. It is more than 14, that means we are dealing with iron deficiency. And this Menzer index, if it is less than 40, that means we are dealing with the thalassemia. One thing is very clear, that in whether it is RDW or it is Menzer index, right? Both the things, in both the cases, an iron deficiency is increasing, and over here it is decreasing. Okay? To see this thing, let's watch the patient's report. I'll just remove this page. Here it is. We'll solve 2 cases, and third is what you have to stop. So a report comes, first thing, watch this. So this would be our step 1. 5.8, it is low. Okay? Because normal range is 12 to 15. So 12 to 15, this is clear, it is low. Sometimes it will be written also low, high, highlighted accordingly. But the step may pata chala, so why do we need 4th step? Ishita, just that's why, right? Deliberately I have said that you'll get the answer of this in 10 minutes, 5 minutes. Right? Next case only. So step 1, right? So this is the step 1, and in this step 1 we solve this. Next, we'll watch MCV. I have MCV, here it is. So MCV is, this will be our step 2. Remember, so many things would be given, but will always be following this order. So even when we'll be studying medicine, here order, right? Every time we'll follow the same orders. Then you'll be following this order for 100 times, you'll be fitting into your brain like cement. 72.4, this is 83 to 101, definitely low, right? It is low. So what the next step? Next step is we'll be going for RDCW, right? So this is RDW, red cell distribution width, 16.2. This is step 3. Yes, 16.2. Normal range is 11 to 14, right? It is high. If it is high, as per our discussion, if it is more than 15, yes, it is more than 15, then what do we suspect? We suspect that this patient would be iron deficiency anemia. This is what we suspect. But no, we want to confirm. So over here, they have already calculated this Menzer index, right? It is already there. But well, this would be our step 4. This would be our step 4, right? So what was the Menzer index? Menzer index was MCV divided by RBC count, RBCC, right? So where is that? So MCV here it is, MCV, you have got it, right? And where is the RBC count? Sabse upar, here it is, RBC count, right? So what we shall do? We shall take this value, 72.4 divided by 2.73. 2.73. They have already given this value, but just pull up the calculator and just see what it is. 72.4 upon 2.73. Roughly, it should be somewhere around 27, right? 27. So this 27, it is more than 14. More than 14. So that's why our diagnosis of iron deficiency anemia, that is confirmed. Approximately 27. So yes, so that is coming to iron deficiency. Akhuji 2.65. Okay. 2.65 नहीं होगा. It must be 26, 27 category. Okay. Roughly 26, 27. So that is what we say, iron deficiency anemia. So this is confirmed. So what we do is, we just check. So this is, now we go for one more. Right? We go for one more test. I mean, one more blood report. You guys do it. Right? You guys do it. Step 1, right? The step 1. 10.14. Right? 10.14. So this is low. Yes, it is low. Step 2. Right? So this is done. Step 2. We go for mean corpuscular volume. Here it is. So this would be our step 2. Step 2. Definitely low, right? Less than 18. So this is also low. Fine. Step 3. That would be red cell, right? This is the red cell distribution analysis. This one is step 3. This is 16. High. Bas khatam, right? We would say that this patient is of iron deficiency anemia. Okay? But we said कि नहीं, we need to calculate. So here they have already given the Menzer index. So we said कि चलो एक देख लेते हैं. Step 4 just for confirmation. This is 11.96. It has to be more than 40. This is low. This is discrepancy. अब ये गड़बड़. This is low. It is less than 14. Less than 14, so then no way we can stamp it like. There are 2 RDWs. Which one? Say we need to go for this one. Corpuscular one. So, right. So this is low. So this is 14. Right. Now, if it is 14, so then definitely it is not iron deficiency. Now there is a discrepancy. See these reports, right? Whether you take this or this is standard deviation. So that is not needed right now. But we go for this standard, this one. This is 16 and this is 11. It is not giving us any conclusion. There is discrepancy. So what you do? We go for, let's go for serum iron profile. Serum iron profile, right? That is what we shall go for. So we went for it. And just for the understanding, whenever there is confusion, Menzer index is the winner. What Menzer index tells, that is the final authority. That's why when you say that when 3 things are confirmed, why to go for 4? This is the reason, right? Whenever there is discrepancy, then go for the Menzer index. What Menzer index tells, that should be final. So we went for serum iron profile. So here is the same patient, serum iron profile. See the serum iron 128, totally normal. In fact, all the parameters, right, they are perfectly within. So much so, transferrin saturation percentage, that is also good, quite good. This is also normal. So it means there is no iron deficiency. Right? It means the patient is suffering from thalassemia. Right? This is a condition. So this is thalassemia. So that therefore, diagnosis, thalassemia. There are various types of thalassemia. So this is how things are to be diagnosed. Clear? So, your opinion on this? Go for the step 1, step 2, step 3. So, okay, you guys give some answer and then say something. What the thought process could be. Because even if we are 21, 22, कम से कम at least 10-12 hemoglobin is chalo, right? So I feel like yes, you are participating. This is step 1. So done. Hemoglobin is low. So we go for step 2. That's right. It is microcytic. Right? So we go for the second step, and that is we went for MCV. So this is the step 2. Step 2. It is also low. So we are dealing with microcytic anemia. Done. MCV is low. Yes, Suchita. True. What next? Now, go further. Okay. Now it's okay. Step 3, RDW, right? So here it is, step 3, RDW. Yes, this is 19.7. Yes, this is high, right? This is the step 3. So when step 3, when it is high, fine. But who said that? Someone. Yeah, Ishita, good one, good calculation. Because over here, Menzer index is not there. Menzer index is not there. So she calculated it. This is what is to be done. So sometimes we'll find that Menzer index is not mentioned. But still, before stamping the diagnosis, right, we need to calculate it. So even if you just calculate this Menzer index, so every time it is MCV upon RBC. So now MCV is 69.3, right? Roughly 70, and RBC is how much? RBC count is 3.8. 3.8. A very wide calculation, right? We just make it 70 and divide it by 4. So still it is definitely more than 40, right? And you calculated and it was coming to 18.23. Yeah, 18.23. So the point is it is more than 40. Yes, you guys are right. It happens. Right? So that's why this is iron deficiency anemia. Right, good one. Just for the confirmation, same patient, just to see whether our diagnosis is and mostly this immediately after that you will find that usually it is done. But no worries, right? See here, right? This is low, correct? This is low. And even the saturation, that is pathetically low. So beyond doubt, we are dealing with iron deficiency in. Next is, now we start with WBC. When we'll be studying hematology, so at that point we'll be going in depth of all these things. Right? WBC is the most confusing one. So over here also same thing, watch the trend and what is its normal range? Normal range, WBC range, it is 4,000 to 10,000. That is the normal range. When it increases, yes, this is what is indicative of infection, but what type of infection? So here, when we say WBC, white blood cell, right, there are lymphocytes. In hematology, all these things, right? Lymphocytes, what to check if MCV is normal, or what to check if MCV is normal. See, why to check step 3 then if step 3? So, no, the point is that when you go for this is step 1, step 2, step 3, step 4. If you follow this order, you get the confirmation. Right? You are very sure that, say, you go for step 4, you give importance to step 4 only when there is discrepancy. Otherwise, step 3 and step 4, if they both are indicative of iron deficiency, then you are 100% sure. But when in doubt, then and then you'll be giving importance to step 4. Right? MCV would never be, say if it is normal, right? If it is normal, so then we are going for, here it is, normocytic, so then the history will come into picture, acute blood loss or myeloma. So myeloma, that means bone marrow, right? So it means bone marrow, that means that is where there would be, we need to go for WBC count. We need to go for platelet count. And that is when we'll find that all the values are down. This is pancytopenia, right? And if it is more, MCV value is more, so then we straight away jump on to check the B12, right? Is there B12 deficiency? Is there any autoimmune disorder? So in that case, you need to go for peripheral smear, right? Peripheral smear. That is what we have to watch, and that's where it will be mentioned. History of alcohol. And also think of that, yes, it could be because of thyroid also. So just go for T3, T4, TSH. Right? In T3, T4, TSH, we'll be going for thyroid stimulating hormone. Hypothyroidism. Thyroid is not responding, right? This TSH is telling again, chal thyroid, kaam kar. So in that case, TSH value is rising. So there will be high TSH value because there is hypothyroidism. Right? When there is hyperthyroidism, usko to haath lagaya and he is on fire. So that means just low TSH and thyroid is getting stimulated. Right? So just remember, in case of hypothyroidism, the TSH value would be higher. Got it? So this is answer of your question. That is when you say that what is the MCV is normal. Right? So if the MCV is normal, so this, when MCT is micro, right? I think you wanted to ask what to check if MCV is normal or macro, correct? Because micro, so this is what we discussed in depth, right? That is when it is less. Right? And Rishikesh, you got the answer? That when we are following step 1, step 2, step 3, step 4, don't make any mistake. We are 100% sure what to do. Right? Step 4, that is Menzer index, is to be given importance only when there is discrepancy, when there is any doubt. Otherwise, okay. So moving on to the WBC. So in WBC, there are various types of cell: lymphocyte, neutrophil, basophil, eosinophil, macro, right? Those monocytes, all those types of various types of cells. In hematology, we'll be going in depth, right? Some are granulocytes. Granulocytes means what? When we stain them, right, they will be able to see these granules, ... the entire process of identification is based on whether the granules are present or granules are not present. So they are called as the granulocyte and the non-granulocyte. And then we'll be watching that what is the shape of their nucleus. If the shape is something like this, bilobed, right? If the nucleus is like that, it is like that, so we'll say that this is eosinophil. What about the basophil? Basophil will be looking like this, this type of nucleus that will be called as the basophil. And when it will come to, okay, I write it also. Though, and all of them, they are granulocytes. Right? There are granules, dotted, they look like dots. Right? So this first one, right? This is the eosinophil. This is how. This is very grossly. I am just telling you. When you watch it. Otherwise, so every cell is like a separate topic. Right? Then this one is the basophil. That's how they look like. And the third one is the neutrophil. Their name is as per their stains. Right? Eosinophil, eosinophil stain. Basophil, non-eosinophil. Neutrophil, no stain. No stain. Right? Over here, it will be having multiple loops. It will be having multiple loops. That's how it will really look like. This is the shape of the nucleus. It is called as the multi-lobe nucleus. Right? So that's how. And yes, there will be the granules. Right? So they are called as the neutrophil. And then, so these are granulocytes, and a granulocyte, that means in this there are no granules. They are like all these are like WBC, right? These are granulocytes, and these are agranulocytes. Right? And in this we have got lymphocyte and the monocyte. Monocytes. So in both of them, so in case of lymphocyte, right, yes, the nucleus would be like this, but rest of the area plain, right? Monocyte, big nucleus, right? Big nucleus, but no granules. So that's the appearance. That's how you'll be looking at it. Then you are doing this, right? See, WBC, you have to watch it from two perspectives. One, let's see the total number, right? Total number. All these are called as the differential count. So first, when we watch the total number, that is combination of all those neutrophils, basophils, eosinophils, or total number. Total number is increased or decreased. When the total number of WBC, that is increased, right? Total number of WBC when it increases, it is called as a leukocytosis. Leuko means white. Leuko means white. Cyto means cells, right? Cis is increase, right? So they increase. When we say leuko, that is white, cyto, cells, and then penia, leukocytopenia. Penia means decreased, cis means increased. So this is leukocytopenia. WBC count has decreased. Easy. So when the WBC count, right, if it is increasing, this we are talking about total. When it is increased, infection. One thing is clear that it is infection, but remember this thing is non-specific. What is non-specific? Just from WBC count is high, we can think of that there is some infection going on. Why? Because WBC, they are our soldiers, right? The moment there is infection, right, all of them, they will come with their talwar and they'll start fighting, right? We'll just come to this leukemia. Just hang on for a while, right? We'll just come to that. Right? So infection, this is non-specific. We don't know what type of infection. Right? There is no infection, but there is inflammation. Inflammation. Well, inflammation is also, that is the site where the blood supply will increase and all of them will come, that they will be increased. Yes, inflammation also will increase. Steroids, right? If the patient is on steroid, and we'll see this thing in slightly more detail. Very interesting, right? It is high. pregnancy, the demand is so high. So in pregnancy, it will increase. So infection, inflammation, steroid, pregnancy, even post-surgery, right? Post-surgery. So whenever the body is facing any of the stress, this will increase. What about decrease? The total number will decrease. This total number decreases when simple, when there is, it is called as the hematinic, right? Then it is called as the hematinic deficiency. So hematinic deficiency means B12 and folate, right? So whether the B12 or folic acid deficiency, sorry, so they will come down, right? Because the raw material is not available. Then comes bone marrow failure, because that's the place where these cells will be produced. Now, if these cells, the bone marrow itself is failing, then there is a trouble. In which case, one, there is leukemia. Right? Leukemia. Patient is under chemotherapy. And in that case, this is given tremendous importance. Then there is one another which is called as the aplastic anemia. So in all these conditions, you'll find that the bone marrow is affected. Or if there is so much of infection, so severe sepsis, when the WBCs are exhausted, their count will go down. There would be few medications, which we'll be learning in pharmac, right? So I'll just write medications. We'll study more in pharmac, because it's a huge topic. So in all these cases, it will start dropping. Now, when it is dropping, so our first thing is, we just see that it is increased, correct? The number has increased. So the increased WBC, then we go for differential count. It's called as the differential count. This differential count, we just watch it and give you the indication that what's really happening. So let's write it like this. That first, the lymphocyte. Why lymphocyte? Very important. If the lymphocytes, they are high, then it is a viral infection. You went for the blood test of the patient, and patient is on antibiotics because WBC count is high, but his lymphocytes are high. There is no need, right? Neutrophil is high. Definitely, this is bacterial infection. So this is the point when we'll be giving antibiotics. Correct. The next one, you find the basophils, they are high. Basophil is high. When the basophil or the eosinophil, when they are high, this is what we'll be studying in immunology. Right? We'll be going in depth about every factor, that how it really affects everything. Right? This will be a superlative topic, right? Including all the immunoglobulins, right? So we'll be immunoglobulin G, A, M, D, E, right? We'll be understanding all of them in detail. So basophil and eosinophil, they both are associated with allergy. But this is asthma. That's a common asthma. Right? Over here also, eosinophil also, that is associated with allergy. But this allergy is because of worms. They are called as the helminths. Right? Or the parasites, right? You can say parasitic infection. One more thing. When the eosinophil is high, it is also associated with fungal infection. Right? Plus fungal infection. This will, when we'll be studying this micro at that point. Otherwise, to go into more detail, something like coccidiomycosis. The coccia means they are like round, right? These are the round. Commonest is coccidiomycosis. I just write it, coccidiomycosis. Whenever the word mycosis comes, that means we are dealing with fungus. This coccidio, that means its shape. Its shape is round, right? So then under the microscope, you watch it, it is like, so this is where the eosinophil values will be higher. And when the monocytes, they are high, right? Monocytes, when they are high, suspect tuberculosis. Tuberculosis, or it can increase even to the viral infection. Now we said so much that increase in this, but kitna? Right? How much increase? So we need to know the normal values. Normal values don't grab, right? It is just the relative value which you have to watch. So normal relative value, you'll find that this is about 60%. Right? When the normal blood is taken, so 60% of them, they are neutrophil. 20%, they are lymphocyte. See, 80% is basophil, they are very less. They are very less. So this is like 60 to 65, 20 to 25%. That is all normal. Eosinophils, about 4%. 4%. Right? Monocytes, they are about 5 to 7%. Sort of 5%. Right? So these are like normal ranges. When the range is increased, coccidiomycosis is fungus. It is, coccidio means its shape. It is a round shaped fungus. Mycosis means it is fungus. Fungus, right? So fungal infection. They are components of WBC. Yes, these are all components of WBC. That's right. And are in blood, how such pathogens get connected to them and make allergies. That's what I'm doing. See, eosinophils, monocytes, right? They all are having different functions. That is what we shall be learning into pathology, right? When we'll be going in depth. So before that, we have to learn the physiology of these cells. And during physiology, we'll be learning that what are the type of receptors which are present on top of their head, right? On these cells, and how do they interact. Right? So that is what we'll be doing it into hematology. Okay, so this is what it really happens. Now there are some very important and very interesting causes, right? Need to know. One, when we say that there is infection, right? You always see if the infection, then ask for the fever. Watch if there is pain, discomfort, all those things should be present. You saw that WBC count is high. What next? Right? So go for, from now onwards, we'll be writing chest X-rays, CXR. In clinics, it is always written like this. Right? So you'll be going for chest X-ray. Why? Infection is there. Right? So you just want to rule out the respiratory tract infection. Infection can be present anywhere in the body. The next is the commonest one, urine, right? So this is, you go for the urine analysis. And in urine analysis, what will you see? You will see the presence of pus cells. Pus cells. So that is the indication you need to fever. Then you might have to go for CT scan. Right? You might have to do what is called as the lumbar puncture. Lumbar puncture. That is when you are suspecting meningitis, when infection is in brain. So during neurology, we're discussing in depth about the lumbar puncture. That is how you just insert the needle into the lumbar area and you take the CSF out, cerebrospinal fluid out, and then you do it. Right? Watch for the skin. Is there any cellulitis? Cellulitis. So then also it can be. Then what about the abdomen? Right? There can be, say, cholecystitis, cystitis, cyst means it is bladder, gallbladder infection. Right? So in that case, watch for abdominal distension, and in that case, you need to go for USG abdomen. USG abdomen. If it is female, so you go for USG abdomen pelvis. Right? During that, tell the female to drink lots of water so that bladder should be full, so that via the bladder, right, you can see rest of the structures properly. So this is how you will be handling a case. Right? It is the second thing. In case of steroids, right, when the patient is sick, if the patient is on steroids, not for any of the reason you might be giving steroids, the patient is having, you want to reduce the inflammation, right? So over here, the WBC count, it will rise. Now this is very interesting. When the patient is on steroid, there would be rise in the WBC count, but that rise would be about from 10,000, it can increase to 12 to 20,000. So if it is within this range, it's okay, right? But if it is 22,000, 24,000, 30,000, then it is not because of steroid. Then there has to be something else. That is what you need to think of, right? Now in steroid, why steroid can lead to such increase? This is one of the wonderful questions which is asked, right? So not very complicated, so that's why we just go into slightly depth of it. Steroids increase WBC count because of this one reason, which is called as the demargination. Demargination. Almost 60% effect. That is, if we say that WBC count increases when we give steroid, 60% effect is by demargination. Very simple. Here is the capillary. Normally, WBC cells, they are sitting over here. So now I just make it fast. Right? These are WBC cells, they are sitting over here. This is the normal location of WBC. But when you give steroid now, to these WBCs, they come in center. So they come in center. Now WBCs, they are here. So what will happen? When you put the needle, right, and you take the blood out, these cells, they will be extracted. Right? So this is the reason that there will be higher WBC into the drawn blood. So WBC comes in center, right, center, and this is more WBC. Is in drawn blood. So this mechanism is called as the demargination, right? Very important, demargination. No doubt there are 2-3 mechanisms. Then there is another mechanism which is called as the delayed migration. I will not be going into more detail of it, but I'll just write it. It is called as the delayed migration. The delayed migration as such is very simple. Here is a cell. These are the released WBC. Now these WBCs, they should go to some of the tissues to act. So that is what is called as the migration, when they go to the tissues. That migration is slowed down. Right? Those cells, WBCs are said to be much of, right? Wait. So that's why there will be more WBCs which will be circulating into the blood, and then you are taking the blood. So that is what you get, a higher WBC, right? So this thing comprises about 30% of the effect, 30% of effect. And then there are other mechanisms which are called as the band release method, etc. But these two, if you say that, then even up to the level of USML, right, you are more than happy for this. So thus we saw two things. One is the infection, second is the steroid. Right? These are the cases when the WBC count is high. The third one, that is the cancer or leukemia. This would be a massive topic, because there are various types of leukemia. Now, leukemia is like either the cells increase in number, right? Or cells, they don't die when they were supposed to die. Those cells, they are not getting exited, or they are not removed from the system if they are on off no use. So unnecessary, non-useful cells, they keep on circulating into the system. So this is where in leukemia, we'll be going into more detail in hematology, because there are 4 types: acute lymphocytic leukemia, chronic lymphocytic leukemia, acute myeloid leukemia, that is when the bone marrow will be involved, and the chronic myeloid leukemia. All these 4, their types, how to diagnose, what are the management, it is absolutely different from each other. And it is this is also, it is like one of the trump questions. If you know this, right, this is something which is amazing. In this case, you need to have 2 things. Just remember this. It is peripheral smear. You take the blood, right, put it on the slide, right, and then you examine, obviously after staining, you examine the slide. That is one. To go into more details, you need to go for what's called as the bone marrow biopsy. Bone marrow biopsy. Right? Needle is inserted through the cortex into the medulla, and from medulla you take the substance out and then you examine it. That is what is called as the bone marrow biopsy, and that will give you the conclusive evidences of whether it is ALL, CLL, AML, or CML. Right? And for any of the catastrophic effect, catastrophic means something which is khatarnak for the body. They are called as a catastrophe. So whether it is MI, myocardial infarction, or it is pulmonary embolism, massive pulmonary embolism, or if it is like a major surgery. All these are catastrophic effects. But in this case, there will be the transient bump up, right? There will be transient bump of WBC count. So don't get alarmed. If it rises, and then it again comes back to the normal level. But these are the major things which you see in clinics, especially when you are really watching the multiple reports. Right? The final thing is the platelets. Platelets which are crucial for the blood coagulation. So once again, we'll be saying that either they are high or they are low. Right? When they are high, platelets, another name is thrombocytes. Right? Thrombocytes. Cytes means cell. Thrombus means one who is forming the clot. Right? So that's why when it is high, we will be calling it thrombocytosis. Thrombocytosis. When they are less, we will be calling it as thrombocytopenia. That means they are less. Thrombocytosis, they will come in that is in case of what is called as the reactive thrombocytosis. So whenever there is any infection, whenever there is any inflammation, so due to that reaction of the body, right, there will be increase in the platelet count. But again, it settles. Then, in case of malignancy, you'll find that value is pretty high. In case of thrombocytopenia, when they are less, so we'll say the bone marrow failure. Whenever there is bone marrow failure, what will lead to? Pancytopenia. Right? It is called as the pancytopenia. So pancytopenia means all the cells are less. RBC, WBC, platelet, all of them, they are less. So in such cases, you need to give the whole blood. Right? In some cases, say for example, it is called as the DIC, disseminated intravascular coagulation. Right? So, but right now, let's not complicate the matter. Let's keep it simple. This we should really talk about. One which is called as the immune thrombocytopenia. Right? Immune thrombocytopenia. So immune means it is autoimmune disorder. Autoimmune disorder, what would it really do? It will destroy its own cells, right? Autoimmune disease. So in that case, in this autoimmune disease, it will destroy its own thrombocytes. And the own thrombocytes are destroyed. So even if you give them the replacement thrombocytes, Right? It can be given. So, but again, it will be of no use because body's own immune system will keep on destroying these cells. So that's about the platelets. So this was like in general, that when the report comes to you, that CBC, the basic CBC, when it comes in your hand, so how you should really look at it. Right? This is just to improve your perspective, that अपना report, right? You start following a sequence. As we'll progress, we'll be discussing more and more. And in hematology, by the end of hematology, you will be knowing about all the values and the reasons behind it. Right? All right. So thank you so much. I'll upload. Stay well, eat healthy, take care, and see you next time. Platelets, they are just for, these are for clotting, right? Thrombocytosis and malignancy, they are increased, right? And when the decreased means all the cells, they are produced by bone marrow, right? Their bone marrow. When the bone marrow fails, so there is pancytopenia. Everything is reduced, and this is the immune disorder. In immune disorder, body's own defense system is destroying those cells. Right? So that is immune thrombocytopenia. So that is the autoimmune disorder. All right. So thank you so much, and see you next time.